Dr. Cheryl Mather, as I said before, Medical Director of Molecular Path in Alberta at the University of Alberta in Edmonton. And I will ask Dr. Mather to begin now. Dr. Mather.
Thanks, Bob. Excuse me. Good morning, everybody, or good afternoon, depending on where you are in the country. So today I'm going to focus on using amplicon-based panels to advance breast cancer care and really discuss the theoretical benefits and limitations of using some different sized panels to evaluate patients who are being worked up for eligibility for AKT mTOR pathway inhibitors, such as the PIK3CA inhibitors and the AKT inhibitors. Let's see if I can get this. There you go. There are my disclosures, very similar to Dr. Lalonde, and a brief agenda. So to highlight the pathway that we're looking at, most breast cancers that are hormone receptor positive and HER2 negative will be treated with estrogen receptor inhibitors. And over time, these patients will develop estrogen resistance through activation of the mTOR pathway and the AKT pathway. So although ER inhibitors work for a while, eventually patients acquire mutations in the PIK3CA or PIK3 kinase pathway, PTEN, AKT, and other pathways that will potentially bypass this pathway and make them endocrine resistant. There are a number of drugs in either development or offered as FDA-approved therapies in these patients that target this pathway. And the different pathways target the PIK3 kinase, the mTOR pathway, there's dual inhibitors or the AKT pathway inhibitors. In Alberta, we were fortunate enough to get industry funding to test for capivasertib eligibility pre-provincial approval of this drug. And that allowed us to offer testing for the mutations in PIK3CA, PTEN, and AKT1 that would make patients eligible for this therapy. But when we got that funding, the question was, how are we going to do it? So it turns out that most of the patients who are capivasertib eligible will have mutations in PIK3CA. And hotspot testing of PIK3CA was very tempting for us because it was cheap, easy, and fast to perform. But we wanted to know whether or not it would be comprehensive enough to pick up the patient population that would actually be eligible for the drug. So we first looked at the mutational spectrum of the mutations that we were going to potentially expect to see in these patients. So oncogenes like PIK3CA and AKT1 are quite amenable to hotspot testing because they typically have hotspot mutations, single point mutations that activate the protein and are recurrent in a large number of patients. In PIK3CA, for example, the hotspots generally occur at positions 542, 545, and 1047. These other mutations are potentially activating as well, but are less common in our patient population. In AKT1, it's very attractive to do hotspot testing because the majority of patients will have a single point mutation in E17K. PTEN, on the other hand, as a tumor suppressor, is much harder to target with a hotspot test. Although there is a hotspot mutation at position 130, you can see that inactivating mutations and point mutations occur across the entirety of the gene, causing inactivation of the PTEN protein downstream. So doing a hotspot to find all of these background patients would be very, very difficult. So we first evaluated the idea of maybe just doing a hotspot test for PIK3CA alone. Would it pick up enough patients that we were essentially getting good but not perfect results and using the most health economically feasible way of identifying the patients who would be eligible for this drug? The panel that we evaluated tests for 19 point mutations across 5 amino acids in PIK3CA. Only takes about 1 day to set up and interpret, and was very, very inexpensive as far as molecular tests go at $200 a sample, including our technologist time and pathologist sign-out time. We also evaluated a more comprehensive or mid-sized panel to see if that was a better option for catchment for these patients. Comprehensive testing or more comprehensive testing is typically an NGS-based solution. And as Dr. Lalonde said, this can typically be either a DNA only or a DNA and an RNA-based solution to look for point mutations, insertions, deletions, copy number analysis, and potential fusions. These different NGS-based panels can be variable and go from one exon to the whole genome, depending on what you're looking for and what you're trying to evaluate in these patients. When we talk about comprehensive testing, we're talking about things that are generally 300, 500, or bigger gene panels. But some of these panels, like the one we use that are considered more mid-sized testing, can do a lot of the same things that a comprehensive test can do. So Alberta has a cancer biomarker DNA panel that is a mid-range comprehensive sequencing solution. And the reason I call it mid-range and comprehensive is because it only tests for about 130 genes. But it covers the hotspot exons of oncogenes and full exon coverage of tumor suppressors and detects almost all the mutations that we would care about in the 3 genes that were eligible for capivasertib therapy. We're also, because of the way the panel was designed, able to detect deep deletions in PTEN from a single exon to full gene deletion. This takes about 7 days to set up and run, and we have the data interpreted by standardized variant interpretation in Cancer Consortium, or VIC criteria, by our certified molecular pathologists. And unlike that hotspot panel, it's a little more expensive. It costs us about $700 a panel to run. We do, however, run multiple bioinformatic platforms on this particular sequencing data to evaluate copy number, where we can evaluate both amplifications and deep deletions of individual genes and portions of whole chromosomes. And we tie that in with a SNP or based approach to look for loss of heterozygosity to confirm those copy number alterations called by the software. This allows us to get down to 1p and 19q deletions at levels around 20% tumor fraction and prevents us from having to send those to the fish the way that Dr. Lalonde's panel does. But it takes specialized design of the panel to accomplish this. Our panel also includes a MSI caller that is better than nothing, but probably not ideal. And allows us to look at SNPs and indels across those 130 genes. Unlike Dr. Lalonde, Alberta does not have the limitations on which genes we're allowed to report in different tumor settings, so we generally evaluate all 130 genes in every patient. This is more time-consuming and potentially less clinically actionable in any given patient, but does allow us to know what we're not seeing if we were to bioinformatically mask those patients. What we're obviously looking for in these patients with breast cancer are these PIK3CA hotspot mutations or AKT1 mutations, PTEN deletions, or truncating mutations, or that hotspot at 130. The drug was actually approved based on comprehensive hybrid capture-based sequencing, and that was the Capitello 291 trial. This was 2 very specific panels that were between 300 and about 520 genes. And we're able to detect everything that we detect in those 3 genes, SNVs and indels, copy number variants, and select rearrangements, although it didn't include PTEN rearrangements. And we are also limited in that we cannot detect PTEN rearrangements. Each of these tests, if we were to send them out, costs over $2,000 Canadian, which is substantially more than our $700 price point. In the Capitello 291 trial, about 85% passed QC, which does not include, as far as I could tell from reading the trial, those patients that didn't even make it onto the sequencer because of insufficient DNA quantity. And that's going to become important in the next slide. About 70% of their patients had sole mutations in PIK3CA that made them eligible for capivasertib. And then about 30% that were eligible for drug were eligible on the basis of either combination of mutations in PIK3CA, PTEN, or AKT1, or sole mutations in AKT1 and PTEN. In Alberta, with our patient population, about 89% passed QC, and just over half of our patients had alterations in that PIK3CA AKT pathway. This, however, is a little bit misleading compared to that Capitello 291 cohort. When I say that 89% passed QC, I mean that we sent almost everybody to sequencing. We will test DNA samples down as low as 0.1 nanograms per microliter by qubit quantitation, and it's only about 11% of those that fail. If you take the Foundation Medicine website as the gold standard for what they require, the recommendation is for at least 55 nanograms of DNA from any given patient. When I looked at our patient cohort and actually did the back calculations, only about 75% of our patients would have that much DNA available for testing. So if we were to send it for a comprehensive sequencing analysis, it would probably be a large proportion of patients that would either become NSQ or failed by their analysis, just because we have very small biopsies and limited material available. Our patient population was similar to the comprehensive analysis in the Capitella trial. About 75% of our eligible patients had PIK3CA alone, and about 8% had mixed PIK3CA and other mutations. So we're seeing very similar proportions of patients with these mutations, but certainly it's not just PIK3CA. So we did the thought experiment. Our CBC detection rate is about 50.4% that were altered and eligible for drug. And our hotspot theoretical detection rate, if we went with that 19 hotspot panel, was only 34.3% of the patients. So a large proportion of the patients that would be eligible for drug by the mid-range panel would be ineligible on the basis of that hotspot test. And although it's tempting to use that very cheap, very quick turnaround time, that's a large proportion of patients that would not be eligible for potentially life-improving therapy. Additionally, what else are we missing? So a more comprehensive assay allows the evaluation of more genes than just the ones that are offered for drug. We are able to find ESR1 mutations for which there are clinical trials in breast cancer, and potentially mutations in hereditary breast cancer genes that need additional follow-up by our medical geneticists. We have ATM, BARD1, BRCA1 and 2, CHEK2, NF1, PALB2, and some of these others on our panel that would prompt referral to medical genetics if seen at high enough allele fractions in the tumors. Additionally, there are other hereditary tumor syndromes that we can pick up as ancillary findings in these patients, assuming that they want to know. We actually allow them an opt-out according to our agreement with the drug company that paid for our testing, that says if they don't want to know about potentially hereditary findings, we won't report them. But most, in fact, 90% of our patients opt in for that. And so we can find mutations that would lead patients to a diagnosis of Lynch syndrome, Dicer mutational syndrome, SDH mutations, BAP1, BRIP1, and some others that might potentially have familial implications. And we do regularly. In the first 414 patients that we sequenced, we found 31 patients with ESR1 mutations in their tumor specimens, which might be eligible for other therapies. We found 68 patients with mutations outside of PIK3CA, PTEN, and AKT1 that could be hereditary and needed workup by medical genetics. And we found 10 patients with possible other hereditary syndromes that were unexpected in the breast cancer setting. What else could we find? So one of the benefits of using a very comprehensive panel is that you have opportunity for discovery. And the more genes that are present on that comprehensive panel, the more, quote, free discovery the lab gets. But there's a moral dilemma with this approach, especially when you talk about the benefits or the limitations of doing a comprehensive panel for turnaround time, required quantities of DNA, and the clinical applicability of those mutations in the setting of active cancer in those patients. So just to make this a visual idea, from hotspot to comprehensive testing, we have costs ranging from $200 to greater than $3,000 a sample. You go from one locus, potentially at the minimum, all the way up to whole genome or whole transcriptome. And your turnaround time could be as short as 1 day or as long as 4 to 6 weeks in the tumor setting. So these things all come at a balance. And you could imagine that the clinical utility is maximized at a certain number of genes. So as we showed that PIK3CA hotspot example, that's not going to have the clinical utility that would be maximized for the patients that were eligible. But the comprehensive greater than 300 gene panel tests far more than the 3 genes that we are potentially looking at for drug actionability. So you might argue that the clinical utility of the panel, given the turnaround time and cost considerations, is actually maximized in these mid-sized panels depending on how they are designed and what you're trying to find in individual patients. Amplicon-based testing, because it requires less DNA than some of these comprehensive hybrid capture-based solutions, does tend to have a lower failure rate compared to hybrid capture-based testing, and a higher detection of actionable mutations compared to hotspot testing. There's a lower cost compared to sending out those testing with that comprehensive panels. And at least in our hands, we feel like we have equivalent detection of the targetable mutations compared to those comprehensive panels. There are some limitations compared to doing hotspot testing. There's slower turnaround time, and it's a higher cost compared to those smaller panels. And any amplicon-based panel does have the potential for PCR-induced errors and artifacts, particularly at those very, very low DNA inputs. Additionally, you only get what you look for. If you're looking at 130 genes, you won't find mutations in the other 270 or 370 associated with the 500 gene panel. And with that, I'd like to thank you for your attention.